topics. Because we know that there are two main complications or morbidities of the related to the ureter, that is a leakage or a stenosis. And when this happens, then I think it takes a lot of burden on the part of the patient, gives stress to the managing physicians. And the treatment of this is endourological and stenting in the beginning at least. And most of the cases should be all right. So therefore it was thought that why should a prophylactic or routine stenting be started? This thought came long ago. However, there were some concerns on the other hand regarding the cost and the associated morbidity. So what are the theoretical benefits of prophylactic stenting? So basically makes the anastomosis technically easier, specifically when you put the last suture at the proximal end of the anastomosis. If the stent is already in place, it is very unlikely that it might take a part of the other wall. So, but these things are of course more individual also, but for a beginner and for the younger faculty, these things are very, very important. Then, as it could be a length of the ureter required can be correctly, more appropriately assessed, kinking could be avoided, and you can avoid a tight submucosal tunnel because when you are doing it over a stent, you have an idea that at least I am giving this much space to the ureter. And most important is that because of its presence, there are some potential gaps between the sutures. Leakage might occur, which may not be clinically significant, but we know that more leakage around the anastomosis can enhance or facilitate the process of fibrosis or the long-term complications in the ureter in terms of obstruction. So this can be avoided, and there are sometimes minor areas of ischemia and necrosis because the harvesting of the ureter is done in a very variable manner by persons who are very experienced, very competent, to those who have just begun. So there are variations. So if there is a small area of ischemia or a hole, when a stent is there, the process of epithelialization can occurs better on this, and you will not find minor leakages in this population. Of course, a major leak, if there is a large area of ischemia or necrosis, that cannot be avoided with a stent. So, but on the other hand, cost and the two main issues of UTIs in larger number and hematuria. So, for last almost 40 years, this has been going on, and most of the studies which are quoted in the literature, they are from the earlier era. And there are at least 100 studies if you go through the literature, but most of them are retrospective. There are only some which are well designed, prospective studies, and then there is a meta-analysis. So I'll take in brief all of it and then try to conclude something. So this is way back in in 2000, we published from SCPGI this first prospective study with the 50 patients in each arm, and showed that there was a decrease in ureteral complications. Here, if you see, there are three parts to this. Here, non-stented, and this is the time when the study was performed, starting from 1989 to 98. Not stented, the complications were more. Here, the complications started decreasing, and then we started routine stenting. So by 2000 in SCPGI, we were stenting every anastomosis. About 12 years later, I reviewed the entire literature again, and then we found that when we compared with the historical group again, because we were stenting everyone, so again we found that routine stenting was useful. This is another study which is again favoring. So I'm not taken many studies, these are just kind of samples and our own experience. So coming over to the points against stenting, as I said, hematuria and UTI, they were the main two issues. For the cost, there were studies addressing this also, and I'll come to that when I come to the meta-analysis and how even in terms of cost, the stenting is better. Then those who were against, they said that when a problem occurs, then the reoperation rates are similar in the groups where they did these studies. So said, and then they also said, the opponents, that BK virus associated nephropathy could be more, but these are all mainly retrospective studies. So this is another retrospective study again showing higher number of UTIs in the group which were stented. Similarly here again a retrospective study, but they have shown a higher rate of UTIs. This study is now important because they actually looked at the duration of the stent, because the stents were being put for a very long time, up to 6 weeks. Then they studied and then they said if the period of stenting was less than 30 days, then the UTIs could be significantly reduced. So this is another study. Again, they are saying that one has to do PCN. Obviously, if there is an obstruction later on or a leakage, it has to be done. So like that, there were studies against this also. Now coming to this is a meta-analysis, and which has taken mostly the prospective randomized studies and some other large retrospective studies also, and the conclusion is that stenting can avoid the minor leakages. It can avoid, like as I said, the theoretical other benefits, avoiding compression, giving better results with the anastomosis. So all those theoretical things. And the meta-analysis is in favor of a routine stenting. These are the main studies included in the prospective randomized trial and through which the meta-analysis was done. Then this is another study where again they have shown significantly lower incidence of the urological complications in one of the major journals, in American Journal of Transplant. So these are the main highlighting points which are in favor of routine stenting. And if you see this graph in the meta-analysis also, forest chart is also in favor of routine stenting. So now, still there are many who do not believe in routine stenting. They go sometimes only for selected stenting in those areas where the ureter or bladder was earlier operated, or during harvesting ureter, you see that the tip of the ureter, the blood supply is not good, the triangle was not maintained, things so on and so forth. For that also there is a study which said that routine stenting was better than the selective stenting. So now if you believe in stenting, then there are these small issues, I'll cover them. That duration, how long should it be put? So as I said, from 6 weeks, then we did a trial again, published, and we said, concluded that if we brought the period of stenting from initially 4 weeks to 2 weeks later on, and with equal efficacy, and the number of UTIs and other small morbidities like hematuria or encrustation, all those things could be avoided. This is another study which is also favoring less than 2 weeks. But there is not much of literature between the adult versus pediatric, which is an area which needs to be explored. Similarly, between the live and deceased donor also, we do not have many studies saying that. But in cadaveric or the deceased donor, I think it is more useful to put in a stent because the blood supply to the ureter is, because of the long warm ischemia and then cold ischemia time would be, logistically compromised. So that should be favored. So basically, at the end, I would say that routine use helps, and it cannot, of course, take care of the major ureteral sloughing, but minor complications which result in major morbidity to the patient later on for management can be avoided. And if you keep the stent for a shorter time, it gives you the benefits as well as the issues of hematuria, UTI and other complications would not be there. Thank you very much.